So you're interested in your health span. You meet with your doctor, you don't want to be rushed. I don't blame you. The system is set up in a way that's not optimal for healthy aging. So let's just have a moment, even sit down, though I usually walk and talk, and discuss your health. First thing I'm going to ask you to do, if you're talking about your metabolic health, other than identify your why, what are your non-negotiables, that's all critically important because it has to be personalized to you. But let's just say you've identified that why. We know what your non-negotiables are. We need to know that blood pressure. I'm not going to stop saying it. If you don't know your blood pressure, you don't know a huge part about your odds for healthy aging. And you don't know your blood pressure unless you're checking it outside of the office. There are a mass load of people who have concordant blood pressures, same in the office as in a nurse's station or a dentist chair or a physician's office. But there is a massive amount of people who have discordant blood pressure. And many of you think it's white coat and it's just that it's high in the office and it's low and normal at home. That is not the whole story. There are millions of people with masked hypertension. They have blood pressure numbers higher outside the office. Their psychology is different. I go to the office, I turn off my phone. Nobody gets to bother me. It's me time. I love my doctor. I'm in a safe place. You can't cookie cut this. You have to check your blood pressure at home. Not only should you check it twice a week, resting in the same spot that you make your blood pressure zone, your place where you check blood pressure. First thing in the morning, after you've voided your bowel and bladder, first thing you're going to do is sit down, put both feet flat on the floor. Your back is going to be against a backrest, and you're going to have a table with your arm at heart level. You'll occasionally check both arms, by the way. And you're going to rest for at least 2 minutes. I know the guidelines say 5, but if your blood pressure is less than 120/80 after a minute or two, go on with your day. No need to spend time. That's where reality meets science. Technically, 5 minutes would be great. Twice a week, a full month minimum to get an idea where your blood pressure is. And don't forget, you're going to want to check it after your 5% fun zones. You're going to want that accountability. You're going to want to see if you have that metabolic flexibility. Okay, you have that reservoir that even despite such and such, after one hit of a night of a little bit too much salt, a little bit too much this, not such great sleep, blah, 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 you're going to want to know not just your idealized blood pressure, only check it when you're being good, whatever that means, because we're all everything, right? We're an amalgamation. You want to check it all the different times so you can have information. We are all going to take calculated risks, but you can't calculate the risk unless you've got data. Okay, moving on from blood pressure. I'm going to want to know your insulin sensitivity. I'm not going to want in a sea of 100 million people with prediabetes to wait until your blood sugar goes up. That means you have had chronic insulin resistance with chronic hyperinsulinemia and now early insulin production burnout. It's not really pre-anything. Now your blood sugar is starting to go up. Clearly, it's a more significant amount of time and more insulin production burnout once you've gotten to type 2 diabetes full blown. But pre is a misnomer. We're going to be changing the name of it soon, and we should. So well before your blood sugar goes up, guess what's up already? Insulin level. Is a fasting insulin perfect? No. Is it better than nothing? Heck yes. It mostly assesses a liver insulin sensitivity. That's fine. I don't need to check muscle sensitivity because I'm going to practically just ask how you're doing. Are you moving around? Are you going to the gym? That's going to be the real reflection of muscle insulin sensitivity. We're not going to be able to do a euglycemic clamp where we put you in a hospital setting and we got 2 large bore needles, one in one arm, one in the other. One's pumping in glucose, the other one's pumping in insulin, and you see how much insulin it takes to control blood sugar at a certain level. That's a research protocol, technical gold standard, not going to happen. Fasting insulin works great. What's that? Optimal? To me, make it simple. Fasting insulin deep into the single digits, probably actually 5 or less, with a fasting glucose of less than 100 milligram per deciliter, divide by 18 if you're using international units, and an A1C less than 5.5. Now, 5.7 is commonly known as the threshold of prediabetes, American Diabetes Association. I am more in line with the American Association of Clinical Endocrinologists that use 5.5 for the at-risk level. So less than 5.5 for A1C, 5 or less with fasting insulin, preferably repeated more than once just to confirm, since insulin is a little bit pulsatile, not so much when you're insulin sensitive though, and a fasting glucose of less than 100 milligram per deciliter, divide by 18 if you're using international units. Then, of course, we get to the lipids. These three things I'm going to keep repeating over and over, and I want to make them as simple as possible. Lipids, ApoB is the gold standard. If you have a very high LDL, a very high non-HDL, which would be even better, that's your total cholesterol, let's say 180 minus your HDL, let's say it's 50, that gives you a non-HDL of 130. That ideal is for population purposes, less than 100, maybe even significantly less depending on your risk of disease. But even non-HDL, which is superior to LDL cholesterol, and non-HDL cholesterol doesn't require fasting either, is still inferior to ApoB. ApoB, every particle that can burrow into the artery wall, I don't know if it's LDL, IDL, VLDL, etc., they all have one ApoB molecule attached. Therefore, we can much more easily recognize what the particle number is for atherogenic particles. Otherwise, you get into situations like measuring LDL cholesterol. It's only 1/3 of what a LDL particle number would be. The amount of LDL cholesterol is part of it, 1/3. The other is triglycerides, and the other is different sizes of the particles. I can just check the ApoB, and there's one per particle. And I don't care if you've got large, fluffy, buoyant LDL. If it's high, LDL particle number is high, ApoB is high, you have high risk, despite it being large and fluffy. This idea that they are large and fluffy particles mitigate risk when the total ApoB or particle number is high is BS. If you have small, dense particles, they're thought of that could more easily burrow into the artery wall. Not true. Large, buoyant particles could definitely burrow into the artery wall as well. But if the particle number is low, the risk is low. Now, usually, small LDL particles are generally correlate to higher particles number, but you don't know that unless you check ApoB, ApoB. In theory, everyone would have a level less than 60. Practically speaking, that's probably not realistic. If you're really young, you're at low risk, you have a family history of living to be 500 years of age and no heart attack or stroke for centuries. I'm exaggerating. Probably getting up closer to 100 or so would be fine unless you're really young. But even if you're really young, knowing that it's a cumulative risk, you'd eventually want to get that ApoB down in the double digits, maybe down even to the 50s if you are at significant risk. I have a very high, last number to mention here, lipoprotein little a. Despite zero coronary calcium score now approaching 60, I am still thinking, all right, I'm pushing the envelope. My insulin sensitivity is great. My blood pressure is great. My ApoB has been good. It's 70 naturally without help, but I added ezetimibe, the cholesterol absorption inhibitor, since I am a hypercholesterol absorber, to drive it down a little lower just to be safe, because ezetimibe is cheap and benign. And the ultimate issue is getting that ApoB down. I don't care if it's with drugs or not. I just posted about the prevent calculator, which has a flaw. And that is, if your ApoB or your what they would use for lipids, as far as I believe they use non-HDL, but nevertheless they use total and HDL, so which is really a way of them calculating non-HDL. Notice that they don't use LDL in the prevent calculator. Okay, they use non-HDL cholesterol. And if your non-HDL cholesterol is controlled with statin, it gives you lower risk than without statin. That doesn't make sense, because if your cholesterol is under great control without a statin, that's even better, because if you're doing it through lifestyle, you're going to get benefits beyond just the lipid control. You're going to get even cancer risk reduction, for instance. So that's a little bit of a flaw. Nevertheless, with that said, you got to know your numbers. Those three areas: blood pressure, checked at home frequently, less than 120/80 if you're not on medication. If you are on medication, change your lifestyle to see if you can get off, and then you'll be less than 120/80 for your goal as well. But if you are on medication, we don't want to push the drugs so high that we push side effects. We will accept less than 130/80. And then obviously insulin sensitivity. Don't wait for blood sugar to go up. Add the fasting insulin as mentioned. Rewind if you want the numbers, or you can actually go to my YouTube page and you can see playlist. Click on playlist, drop down, scroll all the way down to the first item, which is the Flex 5 Lifestyle Masterclass. And that first video will be what is type 2 diabetes. So we go into detail about how fasting insulin goes up first, and then it's typically after meal blood sugar next, which means A1C, and then fasting glucose. That's typically the order, but there's more details, including other forms of not so rare diabetes, like latent autoimmune diabetes of adults and MODY, or maturity onset diabetes of the young, which is a genetic issue. We don't want to miss those diagnoses because they do change management. That being said, you've followed it this far. You want to learn the Flex 5 lifestyle, the mixed martial artistry of health and well-being. Please go to one of two places. You want to start with an appetizer? Excellent. 5-day email education course for the Flex 5, free for you at myflex5.com. MYFLEX, then the number 5.com. 8 characters. MYFLEX, then the number 5.com. Did I get that right? Excuse me, 7 characters, right? Yeah, 4 plus 2 is 6 plus the 5, the number 5 is 7. So lucky 7, myflex5.com. MYFLEX, the number 5.com. You'll see right there on the homepage, free 5-day email education course. Start with the appetizer. When you're ready, go to my YouTube channel and you will click on playlists, and the very top choice file in the playlist is the Flex 5 Lifestyle Masterclass. If you want to start at the beginning, scroll all the way to the bottom. You want to stop in the middle, grocery shopping. I want to see that one first. Watch them in whatever order you like. And click like, click love, click hate, click laugh, whatever you want. Subscribe, share this wide. Love you all. Take care. That's Dr. Tom out for today.